Now we're going to discuss Chapter 3, Policy Implications for Population Health, Health Promotion, and Wellness. The learning objectives for this chapter are going to be to describe the factors that play a role in the shift to population health management, to identify the key players and their roles in federal policymaking for population health, to appreciate the components of population health under the Medicare program and how Medicare policy has shaped commercial insurance, also to understand the design and use of incentives and their potential for discrimination, as well as to understand the key components of the Affordable Care Act and how it influences the adoption of disease prevention services and initiatives in the system. So who are the key players in the policy implementation? And you're looking at the federal level, the U.S. government, the Congress, also the congressional mandated independent organizations, as well as the cabinet level agencies and offices. The federal government influences policy and population health directly as one of the largest purchasers of healthcare, and indirectly as an influencer of private sector healthcare purchasing and delivery. The federal government finances and provides coverage to nearly 130 million people, governmental employees, poor, disabled, elderly, military personnel, and their dependents, as well as Native Americans. Government coverage, payment policies, and ideas regarding system structure go beyond government-managed programs and can directly affect coverage, rate policies, contracting for other purchasers, and payment policies for healthcare practitioners. And then at the state level, you'll have industry and trade associations as well as state Medicaid programs. The U.S. Congress plays a key role in establishing healthcare policy and directly influences population health management by producing broader health policy and healthcare reform. So obviously the U.S. Congress is made up of the House of Representatives and the Senate. So in the House, these committees have jurisdiction over healthcare delivery and payment systems for the private sector, as well as for government programs. And these programs can include the Education of Workforce Committee, which considers legislation relating to employer-sponsored health benefits. The Energy and Commerce Committee, they address public health, Medicaid, pharmaceutical, and other national health insurance issues. The Committee on Ways and Means, they have the authority over bills and matters pertaining to health programs under the Social Security Act and many public health programs. Now in the Senate, these committees have jurisdiction over healthcare policy. The Committee on Finance, what they do is they consider healthcare programs under the Social Security Act, such as Medicare and Medicaid, and other health programs financed by certain taxes or trust fund. And then the Health, Education, Labor, and Pension Committee, or HELP, considers legislation that affects primary health and aging, including issues relating to Health Resources and Services Act and the Older Americans Act. Congressional legislative efforts to enact policy changes are informed by numerous sources, including a variety of congressional mandated independent organizations, such as the Medicare Payment Advisory Commission, or MedPAC, as well as the Congressional Budget Office, or CBO. The MedPAC and CBO are vital to advancing the population health agenda. MedPAC was created by Balanced Budget Act of 1997. It's a 17-member commission, which mainly talks about the health policy expert, or that consists of health policy experts, healthcare providers, and academics. And then also, the MedPAC provides Congress with analysis, recommendations, and reports of issues affecting the Medicare program. MedPAC is relied heavily on by CMS and Congress for their analysis, for critical examinations for existing policy, and case studies to understand the effect of potential policy or payment changes. And also MedPAC studies models of care coordination and treatment of chronic diseases. Now this care coordination efforts are expected to foster better patient understanding and faithfulness to treatment regimes. Now the Congressional Budget Office, or CBO, was established in 1974 to provide data, estimates, and analysis on the financial implications of proposals and spending on the economy. The CBO is required to produce estimates on the effect of both discretionary and mandatory spending. The CBO models have not attributed financial savings to proposed prevention and wellness programs. The CBO said in 2008 that initiatives to improve people's health led to better quality of life, but not necessarily reduced healthcare spending. And then also in 2010, the CBO said clinical and economic effect of prevention services is not sufficiently well understood to precisely estimate cost and benefits. So for cabinet level agencies, their primary responsibility is for implementing legislative policy on healthcare issues. Now, CMS, or the Centers for Medicare and Medicaid Services, they take care of the Medicare, Medicaid, as well as the state children's health insurance programs. Now, as of 2012, there were nearly 110 million people covered under the CMS program. And then the other agency is the Office of National Coordination for Health Information Technology. And this coordination of national efforts to implement the use of HIT, or Health Information Technology, and the electronic exchange of health information. This agency also promotes the development of a nationwide health information technology infrastructure that will lead to interoperable of health information. Under the federal level innovation, you have the Accountable Care Organization, or ACOs, or medical home, as well as the CMS Innovation Center. The ACOs are networks or organizations that assumes responsibility for coordinating the continued care of post-acute care patient referrals. And then, like patient-centered medical homes will ideally become the ACO in the future. Medical homes will increase the likelihood of engagement and loyalty by bringing a closer relationship between the doctor and the patient. Under the CMS Innovation Center, they actually fund a broad range of demonstration programs, including alternate payment and delivery models intended to promote care coordination. The passage of the Affordable Care Act gave CMS the authority to explore other care delivery models via this Innovation Center. Now we're going to look at some state-level case studies. By the early 2000s, nearly all 50 states had implemented disease management or care coordination programs for some segment of the Medicaid population. Now, for the Missouri Medicaid program, Missouri transformed its Medicaid program from provider-centered model to an individual-centered, outcomes-focused model. Now, by doing this, they did this to combine primary care case management, care coordination, and disease management services. Their expectations were to improve adherence, increase service utilization, increase provider use of electric tools, and to improve satisfaction. This actually led to improvements in outcomes, meaning the adherence, service utilization, and costs for participants with chronic conditions. Also, this led to, for diabetes, the adherence to testing and screening had improved. Lipid panel compliance with patients with coronary artery disease and diabetes also improved. And then also there was a decrease in ER visits and costs for the population enrolled in this program. Now, for the Pennsylvania Pay for Participation program, this was developed to reduce inpatient admissions and ER visits by Medicaid beneficiaries. The incentives were paid to providers that utilized guidance-based care and ensured those patients receiving interventions had improved health outcomes. The results? They had fewer inpatient admissions and ER visits compared to those patients not receiving care from a provider not receiving financial incentives. So by providing the provider with financial incentives to keep patients out of the emergency room or by being admitted into the hospital, helps physicians or clinicians to focus mostly on those patients, on their needs and their treatments to keep them out of the hospital and ER. So just by having these incentives have shown great progress towards improving the population health. In order to organize care, information, and services around the health needs and desires of individuals, healthcare stakeholders must embrace these key considerations for policy development. They must understand that there are existing barriers. They must also recognize innovative delivery models, and they also must identify key components of success, the politics of expertise. So for population health management, they have to have flexible models. No single model is appropriate for all settings or populations. Flexible models developed and aligned with the needs of the target population and existing services. These models have shown considerable success. Strategies and components. Now, these are essential solutions for policymakers to consider at both the federal and the state level. Population health management places the patient at the center of the model and intends to improve the health status of the entire population by prevention, wellness, chronic condition support, and advanced management care. Now, some of the key components of population health management: identify the population, determine the individual's risks, stratification based on identified risks, implementation, person-centered model of intervention, organize and tailor approaches based on risk level, measurement of outcomes in areas of physiosocial behavior changes, clinical and health status, quality of life, and financial realms. And finally, the key concepts and proposals shaping the population health strategy. Appropriate use of data and analytic capabilities to target populations most appropriate for intervention. So in other words, timely clinical and self-reported data and analysis is essential to identifying individuals and population cohorts that might benefit from a broad variety of population health management services. Timely data makes sure individuals have not progressed in their conditions beyond the scope of services to be delivered. Availability of care coordination and coaching resources for targeted populations. This is key to effectively teaching patients or their caregivers to manage their conditions and navigate the healthcare system. Evidence shows that improving care coordination has resulted in positive health outcomes. Also beneficial in assisting patients to manage their own conditions. Widespread adoption of interoperable health information technologies. This provides access to relevant data and supports improved outcomes. Improvements in managing patients' information are crucial to improving quality of health care for patients with chronic illnesses and decreasing the cost of care. Electronic health records enhance care coordination, eliminate waste and duplication, and provide individuals with greater resources for improving their own health. Clearly defined metrics for outcome measurements. This process continues by defining guidelines and figuring out best practices for evaluating program outcomes. Policy makes us recognize that no single measure or method of value assessment is appropriate to all programs. And of course, the main goal is to improve health status of the entire population through prevention, wellness, chronic condition support, and advanced care management services. So that concludes Chapter 3. If you have any questions, please let me know. Thank you.